Welcome to today's MESUD Learning Community PMP webinar. Today we'll be hearing from Dr. Stephanie Nichols on treatment considerations for adult ADHD, stimulants or not, and if yes, which, how, and why. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please place all questions in the Q&A function in Zoom. And now I'd like to give a quick introduction to our speaker today. Dr. Stephanie Nichols is an associate professor in the University of New England College of Pharmacy, adjunct clinical assistant professor of psychiatry at Tufts University School of Medicine, and a psychiatric and substance use disorder pharmacist at Maine Medical Center in Portland. And with that, I will hand it off to Dr. Nichols for our presentation. Thank you all for being here today.
Thank you so much, Bethany, and I will echo her words of gratitude for you all sharing our lunch hour here together today. And so I am excited to be with you, and you just heard what we're going to talk about, so I'm just going to dive right in. So our learning objectives by the end of today, we should all be able to describe the epidemiology and pathophysiology of adult ADHD, compare and contrast medication options for adult ADHD, including stimulants and non-stimulant options, and then list treatment pearls for stimulant use, including dose, frequency, and formulation strategies, for example, like short-acting or long-acting, use in special populations such as older adults and those with cardiovascular disease or substance use disorders, and how and when to start, stop, combine, and switch treatments. So diving right in, so what is ADHD? So ADHD is recognized as being a heritable, so there's a large heritable component of ADHD, chronic disorder that is neurobehavioral in nature, and it's characterized specifically by often a constellation of symptoms that may or may not include hyperactivity as well as inattention and impulsivity. ADHD has been in DSM-5 since in DSM since the first one. You can see it was actually called the minimal brain dysfunction in DSM-1. The name evolved over the years, landed on ADD in DSM-3 after moving to hyperkinetic reaction of childhood in DSM-2. ADHD then could have, plus or minus hyperactivity in DSM-4 and now DSM-5. We recognize this as ADHD, and patients can have an inattentive or hyperactive component, or they can have a combined nature of the condition. DSM-5 did add additional information about about symptoms of ADHD and how they might manifest in adults, as well as change the diagnostic criteria just a little bit with regard to the number of symptoms. So in pediatric patients, in non-adult patients with ADHD, there's a requirement that 6 symptoms have to be present in a category. With DSM-5, that is changed to 5 symptoms in a category for adults. So non-adults still do require 6 symptoms, but adults require 5 symptoms in a category. And so an adult could have either a hyperactive impulsive subtype of ADHD with 5 symptoms in that category, or 5 symptoms in an inattention category, have an inattention subtype, or have 5 or more symptoms in each of the 2 subtypes of categories and have a combined presentation. And you can see the symptoms listed here for impulsivity and hyperactivity. In adults, that may look like squirming during meetings, or even getting up to use the restroom frequently without a urological need, sort of feeling restless, inability to engage in quiet leisure activities or in still leisure activities, just feeling sort of on the go, revved up, talking excessively, having difficulty waiting a turn, having difficulty waiting turn in conversations. That might look like a lot of interrupting, or even sort of like what might be perceived as like intrusion on others. Inattention, symptoms of ADHD in adults sometimes look like a person might not seem like they are listening when they're in a conversation with someone. They might have difficulty sustaining attention in tasks, particularly tasks that are not exciting to that person. Might not be able to adequately follow through on instructions, say at work or in an assignment in school, maybe graduate school, for example. Difficulty organizing tasks and activities. Again, those could be tasks and activities related to career, but also household tasks and activities, right? All of that requires a lot of executive activity as well. Losing or misplacing objects, being distracted easily, and just being generally forgetful in daily activities. Many of these symptoms you might already be thinking overlap with many other conditions, right? So some of the symptoms that we just talked about with hyperactivity and impulsivity can overlap with anxiety conditions, right? And same thing with inattention. Some of these symptoms also could be manifestations of other conditions, even anxiety, but some other conditions as well. And so it's really important that the patient does have the constellation of 5 or more symptoms in a given category. Additionally, they have to persist for at least 6 months, and they do have to be present before the age of 12. This was the other big difference in DSM-5 versus DSM-4. It's DSM-4 required presence of symptoms before the age of 7, whereas DSM-5 opened that up and says that the patient has to have symptoms before the age of 12. That means people that had symptom onset at 7, 8, 9, and 10 and 11 now could meet criteria for ADHD with DSM-5, and they did not with DSM-4. The other important thing that did not change with DSM-4 to 5 is that the symptoms need to be present in at least 2 different settings. So a little bit about epidemiology. This is some recent data, just looking at last year from the CDC. And CDC reports over 15 million US adults have ADHD, and more than half of these US adults were diagnosed as adults with this condition. About a third of adults in this country who do have ADHD do take stimulants that are prescribed to them. And about 6% take non-stimulants that are prescribed to them. When studied in a different way, when asking prescribers how many people with ADHD are prescribed medication, the number is 50.4%. So prescribers are saying that about 50% of adults with ADHD are prescribed medication, pharmacotherapy, and patients are saying that about a third of us are actually taking stimulants that are prescribed to people with ADHD, and about 6% are taking non-stimulant prescriptions that are prescribed to them. So there is a discrepancy between the amount of prescribing to adults with ADHD that is seen from a prescriber perspective and what is appreciated on a patient perspective. And some of that might have to do with study methodology as well. Another thing I think is really important to note is that among adults prescribed stimulants for ADHD, and this is again from 2023, this is very recent data, almost 3/4, 71.5%, had difficulty filling their prescription because the medication was unavailable. This is not difficulty filling the prescription because it's a controlled substance or finding a prescriber. This is once all of that has been met, this is someone actually being able to get the medication that was prescribed to them because it's not available. So a little bit more about prevalence and looking at specific demographics. So this is from that same report from the CDC, looking at data from 2023. A couple of things that were pulled out here that I want to highlight. Compared to adults without ADHD, adults with ADHD were more likely to be younger, so they were more likely to be under 50 years of age, were more likely to be non-Hispanic white, and were more likely to have an income below the federal poverty level. So adult patients with ADHD were more likely to fall into those categories. And then adult patients with ADHD were less likely to be non-Hispanic, Black, or African American, and less likely to have a bachelor's degree or higher. And you can see the specific percentages in the chart on the right-hand side. You can see the biggest difference, the biggest delta here is in the age group of age less than 50 years. Okay, so let's get into pathophysiology. We won't spend a ton of time on this slide because I love this, but you might not share my brain and you might not love all of this. So I'm going to hit the highlights for you here. So these are some things that have, these are some gene associations that have been linked to the phenotype of ADHD. So some gene associations, and I'm gonna show you what they are specifically. So really hitting at like dopamine and norepinephrine being a really important part of the pathophysiology process. And the bolded ones here are going to be the ones that have the most consistent evidence of being associated with ADHD. So specifically the dopamine receptor 4 and 5 genotypes, as well as the genotype for the dopamine reuptake pump, that the thing that we talk about when we talk about inhibiting dopamine reuptake, that pump right there, the DAT1 pump, that is also really, really important. It appears to be linked to the pathophysiology of ADHD. Maybe also things related to dopamine metabolism, maybe also things related to the norepinephrine reuptake pump or NET, as well as the norepinephrine alpha 2 receptor. And there's 3 different types of those receptors as well. And you can see the 2 that have been linked are listed here, the 2C and the 2A. But also serotonin. So again, a more important one, more consistent one is the serotonin reuptake pump. So now we're talking about both dopamine and serotonin reuptake pump being important. And then also the serotonin 1B receptor. So now the serotonin 1B receptor in addition to our D4, dopamine 4 and dopamine 5 receptor. And then finally, a couple of other things being associated. So acetylcholine, a couple of our nicotinic acetylcholine receptors. But again, the most consistent evidence here is with the SNARE complex proteins and specifically the SNAP25 protein. And if you remember, this is involved with the moving of the vesicle with depolarization down to the membrane and fusing and docking and releasing essentially. And so that release process of dopamine, acetylcholine into the synapse has also been, genotype has been consistently associated with ADHD. And then finally, there's some evidence with potentially GABA metabolism. But wait, so it's complicated. But wait, there's more. So then we can look at like the pathways, right? Because it's not just about the receptors and the neurotransmitters, but where the receptors are in the brain and how everything talks to everything else. So we know that ADHD does involve cortical dysfunction as well as abnormal connectivity between regions of the brain. So if you look to the right-hand side for a second, one of the most important areas is going to be this red pathway, this frontocerebellar network between the cerebellum over here into sort of the thalamus, but also importantly the caudate we'll talk about in a second, and then out here to the frontal cortex. And so imaging studies have shown that there is a maturational delay, but not a deficit, a delay. It does mature, just delayed in prefrontal cortex development. Additionally, there's reduced total volume and activity in the prefrontal cortex, as well as the caudate and the cerebellum. And the caudate's not on this picture, but if you want to picture it as like the sort of the rat tail kind of at the top here, that's kind of where the caudate is. And then as well as global cortical thickening. And then when we get into this abnormal connectivity, this reduced signaling between the prefrontal cortex and the default mode attention network. And so that in particular is important because while every day, all the time, we are taking in input and stimulus, our brain helps us to filter out what's important. And part of that, and that abnormal connectivity is lost in people with ADHD. There have also been proposed links between ADHD symptoms and impairments in the specific brain circuits depicted here. So we talked about that important frontocerebellar network circuit, but also alterations here with this reward circuit. And certainly, when we're thinking about substance use disorders, we're always talking about the nucleus accumbens and, that link between ventral tegmental area and nucleus accumbens with dopamine. So again, that reward network, but also importance of the frontostriatal network and intentional network, and then of course just broad executive functioning. So there's a lot happening with dopamine and with norepinephrine here with ADHD. And if we want to kind of make it more simple, we can go backwards. And that's kind of where we are in science right now. We know stimulants are like the most effective meds we have in psychiatry. Benzos too. Benzos are pretty effective, but that's all I'm going to say about benzos for the scope of this talk. Stimulants are very effective. They work very, very well. The number needed to treat is like 2, right? It's very low. And so, a lot of our understanding of ADHD is kind of based on going backwards, and that's in psychiatry in general, actually, is going backwards from what we know works medication-wise to trying to understand how that pharmacology might lead and link to pathophysiology. And so we know it's pretty clear that when we use drugs that increase dopamine and norepinephrine in the synapse, that helps to impact the symptoms of ADHD. And so one sort of simple way that I think is very oversimplifying, but is something that you could sit with is the importance of the level of catecholamine release, both dopamine and norepinephrine, but probably dopamine's most important. And that it's not like there's not enough or not too much, but that there's not the right amount in the right spot under the right situation. And so, if someone might present with sort of fatigue, but also maybe in some situations like inattention, that might be where there's not enough dopamine and norepinephrine, but maybe the opposite is true, where if there's too much released, then you get excessive dopamine and norepinephrine. And so let's talk about that a little bit more here. So talking about dopamine release, what happens normally, and then we'll talk about what happens with ADHD. So normally, remember, you've got dopamine. This is your synapse. Sometimes you've seen it like this. It's just sideways, your presynaptic nerve here, your nerve 1 here, and your nerve 2, your postsynaptic nerve here, and here's your synapse, right? So we've got dopamine receptors. We've got the 5 types of dopamine receptors on the postsynaptic neurons, and then we've got some presynaptic dopamine receptors, D2 and D3, that are on the presynaptic neurons as well. And when there's not an action potential, so just at rest, there is a small amount of dopamine that's released from the vesicles, so vesicular dopamine release into the synapse. This is called the tonic pool, and the importance of this is because this dopamine goes back, binds to these D2 and D3 receptors on the presynaptic spot, and sort of says, hey, we don't need any more. Inhibit the release of dopamine, like we're good for right now. So it's sort of a regulatory inhibitory function. Whereas when the neuron depolarizes, then you get, a large amount of release of dopamine, from the vesicles, right? So that process that we talked about is released into the synapse. This is called the phasic pool, and this phasic pool of dopamine is what binds to and acts on the postsynaptic receptors. And so the amount of dopamine that's released in the phasic pool is dependent on how much feedback inhibition is provided by that tonic pool. And then just to round the cycle out here, then DAT is important, remember, for ADHD. And so DAT, the dopamine transporter, is what will then reuptake dopamine to sort of stop dopamine from binding to the receptors in the synapse. So on the top here, this is what happens normally. So you've got a tonic pool. The tonic pool goes over, says, hey, we don't need any more release of dopamine. It inhibits dopamine release. So when there is a phasic, a depolarization and a phasic pool release, it's not quite as large. It's a moderate size phasic pool release. But in ADHD, what's thought to happen is the tonic pool goes down. So the release of dopamine in the tonic pool goes down. There's not as much dopamine release here outside of depolarization when the membrane's at rest. And so you don't get that inhibitory signal the way you normally would on those D2 and D3 receptors. And so when the membrane does depolarize, then you get this large release in the phasic pool and this large amount of dopamine binding to the postsynaptic receptors and this sort of large increase in dopamine tone. So in ADHD, the tonic pool is reduced. We just said that allows for a larger than normal phasic release of dopamine and disorganized behavior leading to inattention, hyperactivity. And so by blocking that, right, so by blocking the reuptake pump and net, stimulants enhance the tonic pool of dopamine and attenuate the larger than normal phasic release, which is caused by the action potential. And that might be why they work so well in treating people with ADHD. But I'm going to talk about drugs the rest of this presentation, except this slide. So pills do not build skills, but they do allow for brain space to work on and build skills in therapy. So non-pharmacotherapy is really important in the treatment of ADHD, and pharmacotherapy is not essential. It doesn't have to be part of the picture. Medications work really well, but they don't have to be part of the picture. And certainly if someone is on medication therapy, that shouldn't be the only treatment. We know that there's a large component of education that goes into someone fully becoming being thriving with ADHD. And so that education does not happen with pills and prescriptions. So cognitive and behavioral strategies are essential, and this can include certainly patient education about ADHD, but also partner and family education. There's a lot of misinformation still out there about what ADHD is and what it looks like. And so this education around the disease process is really, really important. A plan for management at workplace, maybe a plan for management in an academic program if that applies. Teaching organization and organization skills and tools, breaking up tasks into bite-sized pieces. People with ADHD can sometimes get overwhelmed with a very large project, but where they would not get overwhelmed if that same project was broken up into bite-sized pieces. CBT certainly, but also dialectical behavioral therapy can teach the impulse control, right? So CBT teaches mood thought patterns and links, whereas DBT can really help patients with ADHD with impulse control as well as interpersonal relationships, particularly if impulse is leading to challenges with interpersonal relationships, like interrupting, for example. Also exploration around thinking about thinking and sort of like metacognition, and then encouraging things like thinking prior to action, thinking before speaking. Medications, the doses can often be reduced when patients do learn these skills. And often also, patient may not be able to get a medication dose, but they may be able to find periods of time or places in their life where they may be able to be medication free. So for example, there might be a period of time where work for someone might be more hectic and less hectic. And once someone is really engaged in some of those and built those skills, they may find that there are periods of time where they are able to go medication free. It's also important, I just want to briefly say it's important to identify and address other things that are often co-occurring with ADHD and trauma in particular. There's a large symptom overlap between ADHD and untreated trauma. So really identifying if that's present and addressing it is really important. Also mood disorders and anxiety disorders, as I mentioned, and then also substance use disorders. And while all of these things are important to identify and address, I do want to say that it's not necessarily, you don't necessarily need to like treat all of these things, certainly not to resolution before addressing ADHD, right? So often it makes sense to address ADHD at the same time as some of these other things. But that might look like, for example, maybe not using medications, in some situations until something else is been addressed or identified. So for example, if a patient has, say, cocaine use disorder and is actively using, that might be a situation where treating and they have a new diagnosis of ADHD or untreated ADHD with an old diagnosis, that might be a situation where it makes sense for that person to engage in therapy and learn skills, but maybe focus on treatment pharmacologically of the cocaine use disorder first. So that's kind of what I mean by that. So with all that said, medications for ADHD, should they be given? Well, they're not required for everyone. Only half of US adults with ADHD use a medication, but we do know that medications do have important benefits. And one of the important benefits is reducing the development of substance use disorders. So this is a quote from that CDC document that I talked about right at the very beginning. They said it better than I could, so I just left it here as a quote, which is ADHD pharmacotherapy is associated with reduced social and emotional impairment, unintentional injuries, substance use disorders, and risk of death due to unnatural causes. So medications for ADHD do work. They work well. And again, they're among the most effective medications we have in psychiatry, but not everyone with adult ADHD requires pharmacotherapy. I'm going to think about if we've decided someone does have ADHD and they do require pharmacotherapy and they're adult, how do we approach this? Well, Generally, you're going to start with a stimulant. That's what's recommended. Those are the most effective agents. And there's no preference. A patient could start with amphetamine or methylphenidate. If the medication doesn't work, then second line is switch to the other type of stimulant. So, if you start with methylphenidate, then switch to an amphetamine. If you start with amphetamine, switch to methylphenidate. At that point, if the patient is not, if it doesn't work for the patient, they're not responding to that, then it's recommended to switch. So to either switch to a norepinephrine reuptake inhibiting medication like atomoxetine, or viloxazine is one of our newer medications, norepinephrine dopamine reuptake inhibiting medication like bupropion, or an alpha-2 agonist. In adults, the around alpha-2 agonists is much less than the utility in pediatric patients, and some of that has to do with the alpha-2 agonists are pretty helpful for hyperactive symptoms that manifest in pediatric patients, but maybe not quite as much for the way hyperactivity manifests in adult ADHD. And then fourth line is generally combined therapy, but it wouldn't be wrong to consider combining earlier than that. And so when we're thinking about combining, in general, it would be totally fine to combine alpha-2 agonists with stimulants, or alpha-2 agonists with norepinephrine reuptake inhibitors. In general, I would avoid or be cautious about combining stimulants with other norepinephrine reuptake inhibitors, and jumping down to the bottom here, including other stimulants. So avoiding combining stimulants with other stimulants, which are also norepinephrine reuptake inhibitors, but also, avoiding or being cautious about combining stimulants with non-stimulant norepinephrine reuptake inhibitors like bupropion, for example, or atomoxetine. And then finally, it's recommended to avoid combining non-stimulant norepinephrine reuptake inhibitors with each other. So it's recommended to avoid combining, say, atomoxetine with bupropion, for example. So into stimulants a little bit more here. So stimulants are more effective than non-stimulant therapy. That's pretty clear. Stimulants work the best. They work as dopamine and norepinephrine reuptake inhibitors. So they block that DAT pump and that NET pump. They also, depending on the type, also have additional pharmacology. So amphetamines in particular, but not methylphenidate, also increases release, most of norepinephrine, but also of dopamine, and then somewhat of serotonin released directly into the synapse. And so that's a different mechanism between amphetamines and methylphenidates, and that might actually be more important when we think about patients with ADHD who have stimulant use disorders. So amphetamines and methylphenidate, another thing with methylphenidate is it is less likely to cause increased blood pressure, particularly at lower doses. However, one question I have about that is about dose equivalence, because there is a 2-to-1 dose equivalence that we'll talk about a little bit later. Methylphenidate may be less effective in some patients, but again, I would wonder about dose equivalence and whether we're talking about 1 milligram to milligram, or if we're actually talking about equivalent doses, and we'll talk about that a little bit later. And then finally, methylphenidate also may be less likely to be used non-prescribed. And again, that has to do with not having this additional release of dopamine dumping directly into the synapse. That probably is only clinically significant in a small subset of patients. In the vast majority of patients, that probably is not clinically significant, but it may be important in some patients. Adverse effects, so, weight loss and anorexia are common, nausea as well. And then some of those noradrenergic effects, nausea, of course, but also tachycardia, hypertension, insomnia, and anxiety. Anxiety can be a mixed bag, though, because sometimes anxiety actually goes down in people with ADHD once they're receiving adequate treatment, because anxiety around, say, like conversations and not interrupting people, for example, goes away once a patient's brain is able to sort of suppress the impulse controls. So my good friend and colleague nationally, Dr. Mullen, Sandy Mullen, she's great. She's a psychiatric pharmacist. I'm including a couple of her slides in here just because she's fantastic, and I couldn't do them better. So these are some looking at the different stimulant formulations. There's going to be a lot of reference material here that you'll see as we go through this. So on the left-hand side, you can see a comprehensive list of the immediate release types that we have. We have amphetamine, which is mixed amphetamine salts. It includes both amphetamine and dextroamphetamine. We have specifically the D-enantiomer dextroamphetamine. We have methylphenidate, which includes the racemic mixture, and then we have specifically the D-enantiomer of methylphenidate or dexmethylphenidate, and then also amphetamine by itself, although that's not really used commonly in practice anymore. And then you can see the extended release formulation. So the same things, we've got methylphenidate and dexmethylphenidate, we've got amphetamine and and dextroamphetamine. Sorry, these names are all so similar. And then we've got different formulations of methylphenidate, and we'll talk a lot about those. And then we've got some more novel ER formulations. So now some newer novel formulations around long-acting amphetamine products that are orally disintegrated or that are available as long-acting suspensions for people that have difficulty swallowing. Also, we'll talk about lisdexamphetamine being a prodrug, some more different extended release formulations of methylphenidate that we'll talk about, a methylphenidate patch, and then some additional medications. So we do have two prodrugs now. So we have a we have an amphetamine prodrug and a methylphenidate prodrug. So on the left-hand side is our amphetamine prodrug. It's lisdexamphetamine. It is FDA approved not just for ADHD, but also binge eating disorder. And it can be used in adults, and you can see the dosage listed there. It is dosed once a day. The duration lasts up to 14 hours, and it does need to be activated. It needs to be converted via this hydrolysis process. And so that can only happen so quickly. So even if someone uses this medication in a non-oral fashion, they are only going to make so much active drug so quickly. So there's no advantage to using it non-orally. And that isn't a benefit in people that may have that may be not quite in recovery for a substance use disorder. The right-hand side is the newer prodrug. This is the other side. It's a methylphenidate-based prodrug. And you can see, again, it can be used in adults. The dosing is listed there. It's a combination product of this prodrug with dexmethylphenidate non-prodrug. So you've got the dexmethylphenidate that peaks, within 2 hours, and then this sort of dexmethylphenidate prodrug that doesn't peak for about 8 hours. So you get this sort of multiphasic release because of the makeup of the two substances. You can see the duration's a lot longer, so you'd expect that perhaps insomnia might be more of a challenge with this formulation. So going in, again, you're going to have a lot of charts here for you, and I'll make sure your slides are available. So this is a chart that is through the American Association of Family Physicians. This is a toolkit about stimulant medications for adult ADHD. I was part of this back in 2019. I do want to disclose that it was in 2019, so a lot of things have changed since then. But this is it's pretty good there. And why I included this here is because it has a really good breakdown of the onset of action of the different medications, and this is within the methylphenidate types, and then also the duration. And these don't always correspond, right? So you don't always have fast onset and short duration, right? So like with Focalin XR, for example, you can see it's a fast onset still, but a longer duration. So these two columns don't always correlate. What's probably not as accurate anymore 5 years later is the cost. So you probably won't find as much value with the cost as you might have in 2019. The other thing is we know a lot more about words and the importance of the words we use, and so we certainly wouldn't use the term abuse in 2024, but we certainly know that some medications have a higher association of being used in a non-prescribed fashion. So what I would focus your attention on is the two that are lower, have a lower risk of that, and that would be Concerta, that we'll talk about in just a minute here. This is an osmotically releasing methylphenidate component. And then the other one is on the next slide in a second that we're going to talk about, which is an amphetamine type, which we actually just talked about a minute ago, which is lisdexamphetamine. Before I switch away from methylphenidates, though, methylphenidate types, I'm going to show you a little bit more about what's in this here. So the other thing about this, there's different ways that you can like make something long acting with a stimulant. You could change the enantiomer. So the dex enantiomer is a little bit longer acting than the racemic mixture. So that's why the like Focalin exists, because it's the dex enantiomer. It's a little bit longer acting. You can make it into a patch. But the other thing that you can do is you can take like caps and beads, and you can change the ratios. So you can have like immediate release caps, beads within a capsule, and like long acting beads within a capsule, and change the ratios of those. So like Abtensio has a ratio of 40% immediate release, 60% CR, whereas Focalin XR is dexmethylphenidate, so a little bit different than the racemic, but either way, it's pretty similar. So it's 50% IR and 50% DR, whereas you can see this chew tab, Quilichew, is 30% IR and 70% ER. So, if someone needs more control later in the day, then maybe a higher percentage of ER would be a better option. You can see some of them go all the way to 20%, 80%. We'll talk about Concerta being 2278, but it's a little different. It's not because of the tabs. It's a different mechanism that we'll talk about. And then you've got some other ones down here with, Ritalin LA is 50/50 and Metadate CD is 30/70. So that's methylphenidate. We're not done with that. We're going to come back to methylphenidate, but I'm going to shift over to amphetamine for a second here. So we've got mixed amphetamine salts, and we've got the 50/50 mixture for the long acting. We've got an ODT 50/50 mixture here with the brand name Zennies. Then we've got the dextroenantiomer, which has a little bit longer activity. And so we've got the immediate release and then the 50/50 IR long acting product. We've got an amphetamine only suspension and IR product. And again, these are not used very frequently. Most commonly, it's going to be the mixed amphetamine salt component. We've got dextroamphetamine IR, and then that lisdexamphetamine prodrug that we talked about under our prodrug section. And alongside Concerta as being one of the stimulants that is least likely to be used in a non-medical fashion, Vyvanse would be our second one. So Vyvanse, lisdexamphetamine, or Concerta, which is the OROS form of methylphenidate, would be the two that would be least likely to be used in a non-prescribed fashion. So some more charts, some more information for you. These are more of the same drugs, but a little bit more about their available dosage forms and then dosing. I'm not going to go through all the dosing here, just in the interest of time, but I wanted you to have it so that you have it available for yourself. So again, more different, the formulations, what's available, and then the different doses that are recommended. And so now I want to jump into the types and just hit a couple of other things here. So IR Adderall, this is mixed amphetamine salts. It's a 3-to-1 ratio of dextro to levo amphetamine, and you can see that the components, 2 different amphetamine salts, aspartate and sulfate, and then 2 different dextroamphetamine salts, saccharate and sulfate. It lasts about 4 to 6 hours, probably closer to the 4-hour side of things. The extended release product has the 50% long acting beads. So you about 4 to 6 hours after the dose, you get the ER beads that dispel the drug. And so the duration is a little bit longer, closer to the probably 10-hour mark, maybe not quite so much 12-hour in most patients. Dextroamphetamine, this one, it's a little bit longer here. And so, that may be a benefit in some people. And then you can see the dextroamphetamine long-acting product with the 50/50 there. We talked about the prodrug here, lisdexamphetamine being a prodrug that's administered once a day, and it has this, you're using the saturable kinetics to rate limit the amount of amphetamine that's being activated, which minimizes toxicity and also reinforcement. Reinforcement if someone wants to use it in a non-oral fashion. So methylphenidate, these are a little bit different. There's the IR tablets. You can see it lasts about 3 to 5 hours. There's the ER that lasts a little bit longer, up to 8 hours. There's different forms. The methylene ER is this methyl cellulose base. And so you get this polymerized drug that diffuses through the hydrophilic gel, and that leads to disintegration of the tablet. And that seems to be a little bit more reliable and consistent than the waxy matrix, which is what is found in Metadate ER and Ritalin SR. What happens here is that there's a delayed onset because water has to create this channel through the wax, and so you end up with this sustained release. The problem is that sometimes it's inconsistent in the way that the water channels through the wax from patient to patient, and even within a given patient from day to day, and therefore the results can be inconsistent, and that can be challenging. Third generation methylphenidates, big one is the OROS or Concerta. This one's a little bit different. This one has a longer duration of up to 12 hours. It's what they call sort of tri-layer with this core. So there's this immediate release overcoat on the outside, and that provides about 22% of the total dose. So, right away you get this immediate release. But then there's two drug compartments for the second and third layer of delayed release. And so what happens is this is a semi-permeable sort of capsule. Water can go in, but nothing can come out. So once the immediate release overcoat is gone, water kind of starts to come in here. I think about this as those little capsules that you used to be able to buy in the grocery stores, and you'd put them in the bath and they would expand into like dinosaurs and stuff. So that's what I'm picturing here, is this is like a little dinosaur. So water goes in and expands our little dinosaur up here. And to be clear, I'm picturing the capsule is inside the capsule. So our dinosaur is like inside this capsule. So this dinosaur is like expanding out this push compartment, which pushes then drug compartment one out through this very tightly drilled hole that only allows so much to go out of this orifice at a given time for this sort of very consistent release. And then drug compartment two eventually will then reach that hole and then be pushed out for this later delayed release. And so this allows for the duration to be up to 12 hours. An important thing that I think is important to talk to patients about if they're taking this medication is there will be a ghost tablet in their stool. If they see it, it's okay. That's expected. That's just the capsule. The capsule will be empty of drug at that point. It's just that non-disintegrating capsule that comes out in the stool. And there are a lot of drugs that we use in psychiatry that have that, and this is no exception. There are also methylphenidate sodas, which are the spheroidal oral drug absorption systems. And this is a more rapid onset versus like the OROS and the CD, which is like a 30-70. And the reason for that is because this is more like a 50-50. You got a bimodal release here, 50% immediate, 50% delayed release, and the delayed here is via this pH-dependent polymer that releases about 4 hours after the IR dose, because remember, your GI tract changes pH pretty significantly. There is a methylphenidate CD or metadate CD. This is the 30-70. So again, less AM control, but more PM control. The duration is not quite as long as OROS. So if someone has wearing off, then that's maybe this is not the right option, and ROS might be a better option. But if it's not that it's wearing off, but that within this 10 hours, say, or 8 hours, they're not getting enough benefit in the later half of the day, and they're on a 50-50 form, then maybe switching to this might be an option that might make sense. Then there's the transdermal product, Atrana. A couple things to think about here. The patch dose isn't the same as what you would convert over to an IR tablet dose. It's not 1-to-1. And that's because PO has a high first pass metabolism, and you don't get that first pass with the patch. The listed dose is what's delivered over about 9 hours. The onset's about 2 to 3 hours. So the patch is placed and it doesn't start working for about 2 to 3 hours. And then once the patch is gone, once the patch is removed, it's going to keep working for about 2 to 3 hours on the offset either. So there's this sort of delay in on and delay in off. And so the duration effect is actually up to about 12 hours. And so for some people, as knowing this sort of delay and working around that is super easy. For other people, this delay in onset and offset can become a real problem. Not so much for the delay in offset as much as the delay in onset sometimes. Because again, ADHD is a condition of executive dysfunction, especially if patients are not in treatment. Some newer dose forms, there's the long-acting oral suspension. It lasts a lot longer, up to 12 hours. There's also the methylphenidate XR that's now like labeled for a higher dose. So this one's labeled up to 85 milligrams per day versus 60 milligrams per day. So, higher dosing. And then also, this is the first one that lasts up to 16 hours. So they're lasting longer and longer. And, that's great from an adherence perspective. But, insomnia is the other thing that we have to be thinking about. As the drug is around longer and longer, right? How much is still around, maybe not in like steady state, but still around in that other 8 hours while that person is trying to sleep. Another new form that I think is important to talk about here is a methylphenidate with no immediate release dose. So this is called Jornay. It's not on the other slides because it's a newer agent, and not on the other tables rather, but it's Jornay PM. It contains only ER dose beads, and so it starts working about 10 hours after the dosing time, 10 hours. So what happens is someone takes it at the night before and it starts working that next morning. So some advantages, the dose is on board when the person's thinking about taking their next dose. This is really important in particular in adults with ADHD versus maybe children with ADHD, where there's like a caregiver that might be helping that person with medication taking. And this is as opposed to the other meds, where traditionally you're in a trough, right? You just slept and you're in a trough before taking that next dose. And so taking it, having the medication on board when taking the dose may facilitate adherence. There's also a smoother onset, and that is a benefit in some people because of you don't have that immediate release component, so you don't have this sort of like none to a lot. It's sort of more of this like gradual onset, and so for some people that might reduce noradrenergic effects, particularly GI effects, like anorexia in the morning, and then also cardiovascular effects. Disadvantages, I mean, it's brand new, it's expensive, it costs a lot of money. And the other major disadvantages, if a dose is forgotten the night before, like that's it. There's no other options. Like it can't be taken late. If the dose is forgotten the night before and the patient wakes up the next morning, like if you take that dose, and if they take that dose the next morning, it's not even going to start working for 10 hours and it's going to be peaking, while they're at bedtime and while they're trying to sleep. So that's a major disadvantage that does need to be considered. Dexmethylphenidate, I talked about, is the active enantiomer of methylphenidate. It's twice as potent as methylphenidate. There's a long-acting product of it. It's a 50-50. So that's really what I want to say about the different stimulants. Just briefly about switching and starting stimulants, different strategies. Amphetamines are twice as potent as methylphenidate. So like 1 milligram of amphetamine is equivalent to 2 milligrams of methylphenidate, or if we want to talk about doses we use in ADHD, 30 milligrams of amphetamine are equivalent to 60 milligrams of methylphenidate. So that's important. I think a lot of people don't realize that and think about them as 1-to-1, and that may be where methylphenidate has been shown to be not as effective in some studies. If you are switching someone from amphetamine to methylphenidate, consider either so you're going from amphetamine to methylphenidate. So your options are to do a 1-to-1, knowing that you're going to err on the side of caution and you might be halving this person's dose. So you're going to lower their conversion exposure. You could do 1.5-to-1 or 2-to-1, which is going to be pretty close and more reliable to what their conversion would be on a population level, but knowing that everyone's a little different. And then in some patients, this might be too aggressive. And so generally that is reserved for a situation when a dose increase is needed in addition to the switch. Or the other way that you could go about doing this, although this is, erring on very cautious, would be to start with a recommended initial methylphenidate dose by the FDA and titrate up accordingly. That would be the most cautious way to do it, but it might leave your patient untreated for a period of time. When you're going from the other way, so methylphenidate to amphetamines, generally it's recommended to observe the 0.5-to-1 ratio. So, give half the methylphenidate, so if they're on 60 milligrams of methylphenidate, give like half of that, so 30 milligrams as amphetamine to provide similar exposure. And that's really your option. There is generally not recommended to do a 1-to-1. That would be doubling this person's dose. And we don't generally do like 0.25 to 1 here. But I suppose you could if you wanted to be very cautious. So treatment effect size here. So again, stimulants are the most effective, but atomoxetine alpha-2 agonists are also effective. This evidence is coming out of the pediatric world. I do want to make note of that. And so in adults, I do not expect that alpha-2 agonists would have quite the same treatment effect size in adults as we do see in pediatrics. We do see I would say that 0.7 is probably pretty close to what we see in adults for atomoxetine though. So the last one from Sandy, it's non-stimulant ADHD medications. So we have our norepinephrine reuptake inhibitors. We have 2 of them. We actually have 3 if you include bupropion, but that also is dopamine reuptake inhibition. So looking at the sort of more specific norepinephrine reuptake inhibitors, atomoxetine and viloxazine. Atomoxetine does have a longer time to onset, and some of that might have to do with it being more specific to norepinephrine, whereas viloxazine actually does have additional pharmacology that I have like 4 really complex slides on that I did not include here because I felt it was a lot. But there's some other stuff going on with viloxazine too. You can see the duration of both of them is 24 hours, so they're once a day dosing, and there are some considerations with 2d6. We've also got our alpha-2 agonists, clonidine and guanfacine that we'll talk about briefly. And then we've got bupropion is really going to be our most important workhorse here in adults for non-stimulants. So non-stimulants, we've got atomoxetine, clonidine, guanfacine here. Their formulations and dosing is listed. So atomoxetine, norepinephrine reuptake inhibitor. None of these non-stimulants are controlled substances. So all of these agents we're talking about now are non-controlled substances. So they could be an important option in people who have active non-prescribed stimulant use. And this is not for ADHD. This is not to say I'm not at all talking about the use of stimulants in the treatment of stimulant use disorder. That is a whole nother discussion and a whole nother talk. I am not talking about that. I am talking about for ADHD specifically. Dosing, most important thing for atomoxetine is to titrate up. Norepinephrine causes a lot of that GI adverse effect, that nausea, abdominal cramping, pain, and that's a big reason why a lot of patients can't stay on this atomoxetine. So titrating it up and, starting even lower and going even slower is totally okay to minimize the nausea and GI effects, but keeping in mind it's going to take weeks for the onset of effect of this medication versus stimulants, which are like, within the first dose or several doses in some people. So kind of thinking about atomoxetine is more like SSRI in our anxiety world, whereas benzodiazepines, where stimulants are kind of more rapid acting like benzodiazepines in our anxiety world. The difference in this analogy would be that we do have people on long-term stimulants where we would not generally have people on long-term benzodiazepines as frequently anymore. Adverse effects of atomoxetine are noradrenergic in nature, nausea, vomiting, cardiovascular, hypertension, tachycardia, dry mouth. It does carry the FDA black box warning for suicidal ideation. And then bupropion is a norepinephrine dopamine reuptake inhibitor, really great option in our adult patients who also have tobacco use disorder or who have major depressive disorder. And frankly, it's also an option in the antidepressant world that's less likely to cause a shift into mania in our patients who do have bipolar disorder. So it's not that, so I would not consider it contraindicated in someone with bipolar disorder either, but I would watch still for a shift. And it's also a great option to consider in people who have obesity. There's a combination product that includes naltrexone and bupropion that's FDA approved for obesity, but bupropion also has weight loss as part of its adverse effect that could be of benefit in a patient who has ADHD and obesity. But the other side is it causes seizures in a dose-dependent fashion. So definitely really need to consider that and generally avoid with a seizure disorder. Avoid if someone has severe active alcohol use disorder because of the risk of seizures in acute withdrawal. And then also if someone has active bulimia nervosa or anorexia nervosa. The risk there is seizures and also cardiovascular toxicity directly related to the electrolyte abnormalities. So if someone has a history of bulimia nervosa or anorexia nervosa, that doesn't necessarily mean that bupropion is contraindicated. It's only if it's active. Adverse effects, I think we hit on most of these. Again, weight loss is sometimes a benefit with this medication. The cardiovascular adverse effects and then seizures. And then alpha-2 agonists decrease noradrenergic transmission, particularly in the prefrontal cortex. There are some that are approved for ADHD, like Capve, clonidine ER, and Intuniv or guanfacine ER, and some that are just used off-label, like clonidine IR, which is approved for hypertension. And I don't really have a lot of else to say about that, except adverse effects, hypotension, right? So clonidine is approved for hypertension. So it might make sense to you that these medications can cause hypotension in some patients. So that's something to watch for. And then also sedation. And this varies a little bit depending on the different alpha-2 agonists. Clonidine tends to be a little bit more sedating than guanfacine, for example. And then the other thing is if someone is on an alpha-2 agonist for ADHD and they've been on it for a period of time, usually weeks, then it is important to taper the patient off because they can develop rebound hypertension if they've been on it. Couple more resources for you that we are not going to go into because I do want to have some time for questions. But this is from the AAFP Adult ADHD Toolkit. I was also involved in this, and I also want to acknowledge that this was back in 2019, so things have changed a little bit, and particularly around language. But on the right-hand side, you can see the overview of treatment recommendations for adult ADHD, specifically around if patients have like a comorbid substance use disorder, for example. And the link is right there for you. You also have links to more information about specific patient groups, a link to the AAFP ADHD prescribe or provider frequently asked questions, and a link to the AAFP treatment page. An additional link for you here for resources for patients. You can see part of it, but there's a lot more. This is a different frequently asked questions, but it's for patients and it's around psychostimulants. And that brings us to the end. So hopefully I have provided you with a full toolbox of effective tools and things to consider as you care for your patients with ADHD. And I would love to know what questions you have. So
Thank you so much, Dr. Nichols. It looks like our first question is from Andrea. What is your position or experience with starting or continuing treatment with stimulants concurrent with known daily or frequent use of cannabis?
yes, so that's a great question. I think that's a lot of people are wondering that. I don't have my hands on data about that, and I think it's something that needs to be considered. We know that cannabis, especially daily cannabis, absolutely is going to contribute to or cause many of the symptoms that we see with ADHD, and we don't have biomarkers, so we don't have a good way to say like definitely ADHD or not. And so that gets really, really complicated. That said, from a harm reduction perspective, like if someone's using daily cannabis for pain instead of opioids, then the net risk versus benefit might still like be in favor of keeping the cannabis on and then thinking about treatment of ADHD and if the benefit, is of using stimulants, in that case, using it. So I think there's a lot of if, ands, or buts there. Yeah, there's so much to that question. I really appreciate you asking that. And I don't have a great answer, and I definitely don't have any data, but I think it's sorely needed. But my position, I would say, is it's probably individual, depends on the specifics, which I know is not the best answer. Sorry.
Well, thank you. We have Dr. Mock, I'm going to use your second question because we're short on time. That she recently had a patient or was reviewing people in their 60s with stimulants who develop CAD. What is important to weigh in on risk benefit? She recently reviewed a convo between a psych NP and a cardiologist who really did not give good advice after patient had MI.
Oh, that's great. So those are some more slides that I got rid of. So there are two studies that have looked at cardiovascular risks in people on stimulants, although there might be new stuff since I've looked specifically at that. But one study did not show an increased risk, and the other, I don't think it was protective, but it certainly wasn't increased. It did show statistically protective, but again, I don't buy that, but I feel reassured that there wasn't an increased risk in development. And I believe this was of MACE, of major adverse cardiac events. I believe if I'm remembering correctly, but I can get that information and make it available for this audience to have. But so all of that to say, the unless there's new evidence that's come out, and I will look as soon as we finish, my understanding is that the risk is not as great as we once thought. However, all of that said, that would not include as many older people.
You. Since we are at the end of our hour, we are going to save the rest of the questions that were included in chat, and I will pass them on to Dr. Nichols, and we will answer them by email, if that's okay with you. And you will also, participants will receive an email with the survey link and the and the slides, and also join us on December 17th, where Dr. Mallow is going to be talking about ADHD in adulthood as well. So December is ADHD in Adulthood Month at MESUD. But thank you so much, Dr. Nichols, for your presentation today. And thank you everybody for joining us today. And we hope to see you all again soon.
Thank you, Bethany, and thanks everyone.
Thank you. Bye.